When you picture one, you probably think of a machine that just, pumps air into a person. Simple enough. But the real story is so much more fascinating. It's this constant, delicate dance between delivering life-saving oxygen and protecting the very organs it's trying to save.
And that really gets us to the core question here, doesn't it? How can a machine push air into these incredibly fragile, balloon-like lungs over and over again, thousands of times a day, without completely wrecking them? That is the fundamental challenge we're going to unpack.
So first things first, what are we actually talking about? Well, at its heart, mechanical ventilation is life support, plain and simple. It's for when a patient's body just can't do the work of breathing anymore. They're in what's called respiratory failure, and this machine steps in to take over the job, either all the way or just helping out.
To really get why this is also complicated, we have to start at the beginning. We need to ask, why is this pretty dramatic intervention even necessary in the first place?
Well, it usually boils down to one of these reasons. Maybe the patient's lungs are really, really injured, like with something called ARDS. Or maybe their brain's signal to breathe has been turned down, like from an overdose. It could be a physical blockage, or maybe their muscles are just too weak to take a good breath. Sometimes it's simply to protect their airway if they're unconscious. But the common thread through all of these is that the body has lost its ability to manage on its own.
All right, so the patient's on the ventilator. Now what? Well, this is where the whole game changes. From the very first breath that machine delivers, the number one focus, above all else, is safety.
And honestly, this quote right here says it all. The guiding philosophy, the absolute core principle, is something called lung protective ventilation. It's not just about getting oxygen in, it's about doing it in a way that protects the lungs while they have a chance to heal. And this is the great paradox of the ventilator. The very same pressure that pushes in life-saving air can also cause serious damage. So the goal is to walk this incredibly fine line, giving just enough help to keep the patient alive without tipping over into harm. And that harm has a name: ventilator-associated lung injury.
So what does that injury actually look like? Well, the first big danger is called volutrauma. I want you to picture the tiny air sacs in the lungs, the alveoli, as millions of tiny, super delicate balloons. Volutrauma is exactly what it sounds like. It's the damage you cause by constantly overinflating them, stretching them out breath after breath. The second major risk is atolech trauma. Okay, stick with the balloon analogy. Now imagine those little balloons are kind of sticky on the inside. If you let them collapse completely, every single time, they stick shut, and then it takes a whole lot of force to pop them back open with the next breath. Doing that again and again and again, well, that creates a ton of stress and injury too.
So how do doctors actually fight back against both volutrauma and atolech trauma? Well, it's not guesswork. They follow a very strict set of rules, a data-driven playbook for keeping those lungs safe.
Rule number one is probably the most important, and it's a little counterintuitive. Use small breaths. But here's the really clever part. The size of the breath, which is called the tidal volume, isn't based on a person's actual weight. It's based on their height. Why? Because think about it, your lungs don't get bigger if you gain weight. So using small, height-based breaths is the absolute first line of defense against overstretching those little balloons.
And here's the magic number that has been proven to save lives: 6 milliliters of air for every kilogram of a person's predicted body weight. It seems like a tiny amount, right? But sticking to that small number has made a huge difference in patient survival.
Okay, next, the clinical team is constantly watching the pressure. But, and this is key, not all pressure is the same. There's peak pressure, which is basically the pressure it takes to get air through the pipes, or the airways. That can be high for lots of reasons, but the number they really care about is the plateau pressure. That's the actual real pressure inside the balloons, the alveoli, once they're full. That number tells you how much stress the lung tissue is actually under.
And that pressure, the plateau pressure, has a hard safety limit. You can see it here, 30 centimeters of water. You can think of this as the absolute red line. If the pressure goes above 30, the risk of volutrauma skyrockets, and the team knows they have to make a change, fast.
So let's just put it all together on one screen. It's like a 4-part safety plan. You've got the small tidal volume and the low plateau pressure. Those two work together to prevent overstretching. That's your volutrauma defense. Then you have a setting called PEEP, which adds just a little bit of constant pressure to keep those sticky alveoli from snapping shut, preventing atolech trauma. And finally, you only use as much oxygen as you absolutely need, because too much can be toxic on its own. See how it all works together?
But here's the thing. Even with this perfect lung protective strategy, mechanical ventilation is still a massive intervention, and it creates risks for the entire body.
Yeah, the dangers go way beyond just volutrauma and Atilec's trauma. All that pressure can literally pop a lung. It can also squeeze the heart and make blood pressure plummet. The breathing tube itself becomes a highway for bacteria, leading to pneumonia. And get this, if you don't use your main breathing muscle, the diaphragm, it starts to get weak and waste away, which makes it way harder to ever breathe on your own again.
Which of course brings us to the most important and hopeful part of this whole journey, getting off the machine. This isn't just a flip of a switch. It's a very careful, step-by-step process that they call liberation.
And that path to breathing alone really has 3 main hurdles to clear. First, you have to pass a readiness check. If you do that, you get to try the big breathing test. And if you ace that, then you can finally begin the liberation trial.
So that first step, the readiness check, is all about the big picture. Is the thing that put you on the ventilator in the first place actually getting better? Are your oxygen levels okay with just a little bit of help? Is your blood pressure stable? And maybe, most importantly, are you even trying to take your own breaths? If it's a yes to all of those, then it's on to step 2.
So once a patient is deemed ready, they face this really clever test. It's called the Rapid Shallow Breathing Index, or RSBI. It sounds complicated, but it's a really simple and powerful idea. It just looks at how fast you're breathing compared to how deep each of those breaths is. It's basically asking, are you breathing efficiently, or are you just kind of panting and not really moving much air?
And that test has a clear pass-fail number. A score under 105 is a great sign. It suggests a patient's breathing is strong and efficient and they have a really good shot at success. But if that number is over 105, it means their breathing is too fast and shallow and they're probably not ready yet. If they pass the RSBI test, they get to start the final trial. This is called the spontaneous breathing trial. The ventilator support gets turned way down, and the patient has to do most, if not all, of the work of breathing for anywhere from 30 minutes to 2 hours. It's like the final exam before that breathing tube can finally come out.
So, when you pull back and look at the whole picture, it's clear that a ventilator isn't just some dumb pump forcing air into lungs. It's this incredibly delicate, data-driven conversation between the machine, the clinician, and the patient's body. It's a constant balancing act on a razor's edge, and it really makes you wonder, right? What other medical technologies out there are hiding a similar profound balancing act just beneath the surface?